Hello, everyone. Good evening. Welcome to the ophthalmology session, and I hope you all are excited as much as I am to do the most expected, most important 25 questions of ophthalmology for the upcoming FMG 2025. So, hello, good evening. Hello, everyone. Good evening. Hi, Kalyani. Hi, Aditya. Ophthalmology Pearls. Hello, everyone. I hope you people are doing fine. Please let me know. Waiting since long for this session. Thank you. I hope this session brings best of the ophthalmology for you. Please let me know if my audio and video is good to go. And those of you want to annotate this PDF along with me, I have just shared the PDF, unannotated PDF on my Telegram group. So you can go download it and you can annotate it along with me, right, guys? Hi, Dheeraj. Hi, hello, everyone. So, yes, it will be available on the YouTube, but in order to have the best benefit from it, I would say that you should join live along with me, get the PDF from the Telegram group, and start annotating along with me, guys. Yes, so is it audible and visible also? All right, so we will start with the first one. Now, don't take it just as a question, take it as a topic also. All these topics are important for your upcoming examination. See, the language of the question may be twisted here and there. Okay, but the question will be there, and these are the 25 topics with which will definitely touch your exam, and your exam will definitely touch these topics, I'm sure. All right. So let's get started with the question number one, where we have a 60-year-old patient who is coming with the dacryocystitis, okay, and she is complaining of tearing, discharge, swelling at the inner corner. So whenever we are having a swelling at the inner corner of the eye, they are always showing you dacryocystitis. It can be acute dacryocystitis, it can be chronic dacryocystitis. The clinical findings are also consistent for chronic dacryocystitis. So, what should be the treatment of choice for this patient? Now, as this patient is having two things. Number one, she is 60-year-old, and secondly, she is having chronic dacryocystitis. So, there is no use of massage, syringing, or probing, and straightforward we have to go for the surgery. Hello, Radhe Radhe, Kalyani, Stuti, Dheeraj, Hariom, Rizwan. You all have given the right answer, and along with this, we should also know the treatment of the dacryocystitis. The dacryocystitis. Whenever we are talking about the treatment, you should always remember that number one is between 0 to 1 year. All those children who are between 0 to 1 year, there we are doing the lacrimal sac massage and not in the adults. Tell me the name of this massage, and along with this we will also give the topical antibiotics, right? Because most of the time we have the evidence of infection in the form of sticky discharge. So we will give the topical antibiotics also. Along with this, massage is very, very important. What is the name of this massage? Can you tell me what is the name of this massage? Then between 1 to 2 years, when you have already done the massage, then we can do the syringing. Now this syringing is done with the normal saline, and forcefully we will try to inject the normal saline so that we are able to open this membranous occlusion. Then between 2 to 3 years, we are doing the probing. Then we are doing the probing we are doing with the help of the Bauman's lacrimal probe, and between 3 to 4 years you cannot do the surgery. So this is syringing and this is probing. We are doing alternate. Here we are doing the alternate syringing and probing. Here we are doing the alternate syringing and probing. It is the Krigler's massage. It is not Trigler. It is Krigler's massage that we are doing. Okay, Krigler's massage hai. And finally, after 4 years, we will do the DCR surgery. We will do the DCR surgery. Can you tell me what we are doing in DCR surgery? Another important question. So, you should know the Krigler's massage, the timing of this. Then, this DCR surgery is done between the lacrimal sac and the middle meatus. That is another important thing. Middle meatus. And you should also know the name of the probe. The name of the probe is the Bowman's lacrimal probe. So these are the other questions that can be there on the dacryocystitis, right? So please see question number 1 is okay. Then coming to the second question, again a very very important topic for your upcoming examination. One question definitely will touch this. A 45-year-old male is coming with a history of trauma with a vegetative material. Now can you get some idea, when we are having trauma with the vegetative material, which kind of corneal ulcer we are expecting? Can you tell me? Number one. Then we are having the eye pain is there, redness, tearing, photophobia, and see they are also telling you septate hyphae at an acute angle. So what is the most likely causative agent? If they are saying hyphae, you cannot have bacteria, virus and acanthamoeba. Hyphae is in the fungal only, plus you have history of vegetative trauma also. And yes, exactly, you all are correct. Therefore, the answer is the fungal corneal ulcer. Now, whenever you have to solve the question on the fungal corneal ulcer, always remember that in cases of fungal corneal ulcer, the history of vegetative trauma is very, very important. They can say farmer by occupation, coming from the rural background, they can say. And the most common fungus. The most common fungus is the aspergillus. The most common is the aspergillus, followed by the fusarium. This is another important thing. Steroids are contraindicated. Another important question. Steroids are contraindicated. Then another important thing here, signs are always more than symptoms. I am telling you the key points that will help you in finding out that it's a fungal corneal ulcer. Then always it will be dry looking. This will be dry looking and grayish. While if it is bacterial, it is never dry looking and grayish. Then you will have multiple satellite lesions. Another important thing about the fungal ulcer, if you are getting these things, you are sure that it's a fungal ulcer, satellite lesions, along with the feathery margins. Along with the feathery margins, and because it has got the hyphae. Because it has got the hyphae, therefore the hypopion which is found in the fungal corneal ulcer, it is the it is always non-sterile as well as non-mobile. Non-sterile as well as non-mobile. Very, very important. Very, very important. Matlab, you cannot have the ophthalmology and FMGE without these questions. Very, very important. Treatment of choice finally to complete is the netamycin. Treatment of choice is the netamycin with the aspergillus. So, very good. Stuti, Shanawaz, Dr. Sam, Dheeraj, Kalyani, Rizwan, you all have given the right answer, and this is our question number 2. Very good. Now coming to the question number 3, we have a male patient, 60-year male, who is coming with the visual disturbances. Now he is unable to see the left side from the left eye as well as left side of his right eye. So left side of both the eyes. Can you tell me what is this kind of visual disturbance? Left side he is not able to see in his both eyes, and he is noticing one more thing, that central vision is intact and it is unaffected. The patient denies any trauma. What is the most likely visual defect of this patient? You have to just name this defect. Is it left-sided defect? Is it right-sided defect? Is it homonymous? Is it heteronymous? And do we have something else also? So is it a quadrant anopia? Left side of both the eyes. See, we have two side of the eyes, right side and left side. So half of the vision is gone. Left side has gone. So it is not quadrant anopia. Okay, it is the hemianopias. Is it C or is it D? Is it C or is it D? And it is the left side of both the eyes. So it is not heteronymous also. Okay, na? Left side of both the eyes is getting blind. Therefore, it is not heteronymous. It is same side. Now the option is that whether it is C or whether it is D. So they are saying that there are central vision which is intact. Because central vision is intact, therefore it is macular sparing. So answer to this question will be D. Yes, central vision is intact. A buzzword. Exactly. That is very, very important. Don't leave that thing. And where do you get this? Whenever we have homonymous amyotropia, this is from the level of optic tract. From the level of optic tract, you are getting this homonymous amyotropia, which is actually contralateral homonymous amyotropia, and macular sparing is found in the cases of the visual cortex. When we have lesion of visual cortex, or they can also say the occipital lobe, or they can say the occipital lobe, any of the following, visual cortex or occipital lobe, then we will say macular sparing. Why we have the macular sparing? Due to the another important thing, why we have it is due to the double blood supply. Due to the double blood supply, we have the macular sparing. What is this double blood supply? It is posterior cerebral artery with middle cerebral artery. Please see from question 1 to 3, we have done 3 important topics, 3 important questions. Anything you want to ask? Yes, and if I ask you what will be the site of the lesion, they have asked you the visual defect, because it is always contralateral homonymous amyotropia. Here we have left-sided defect, therefore we will have right-sided lesion. So it will be right occipital lobe, because we have the macular sparing also. Therefore, the site of lesion here will be the right occipital lobe or right visual cortex. Is that clear, guys? Is it okay? Coming to the next question, again a very, very good question. This is a 50-year-old male who is complaining of experiencing vertical diplopias walking downstairs. Vertical diplopia means we are having vertical squint. Very, very clear cut hai. We are having a vertical squint. Now, vertical squint will occur in which cranial nerve palsy? You can tell me the answer directly, even before going through remaining question. It is said that she is also tilting her hand to one side. So head tilt is also there, and we are having the vertical diplopia. Now, there is a very, very simple formula here. All three, SO4 and LR6. Okay. Now, this will give me horizontal. This will give me the esotropia horizontal. Third nerve will give me down and out. Okay. And there is no head tilt. Head tilt is here and here. This is giving me horizontal with head tilt, and this is giving me vertical with head tilt. See the simple formula aa gaya. The type of squint, and this is for the head tilt. So if I am getting vertical as well as head tilt, therefore my answer is the fourth nerve palsy. So if you know this much, directly you can do, because third nerve palsy mein we do not have head tilt. LR6 may we have head tilt, SO4 may we have head tilt, but one has horizontal squint, one has vertical squint. Now they are saying vertical squint along with the head tilt. So answer is the fourth nerve palsy. Right, guys? Is that okay? Understood? Moving towards the next one, here we have a 35-year-old female coming with discomfort, pain, sensation of pressure, something is there, and also it's a reducible proptosis. Now at your level, if you remember, I told you that if it is a reducible proptosis which is varying, it is always orbital varices. So they can give you different languages. It is increasing on bending down, it is decreasing on bending down, it is varying with bending down. So it is reducible, means it is changeable. So if it is a varying kind of variable proptosis, a term called as the variable proptosis. So V for V, whenever we have the variable proptosis, it is due to the varices. Remember it, V for V, variable proptosis is due to the varices, right? Then another important question, guys, see this. So this kind of question even was there in NEET PG 2024. A patient is coming with the visual field effect, you can see here. So what is the probable site? Can you tell me the name of this lesion? So as this is a visual field, towards my right side is the right eye, towards my left side is the left eye. So this is the right side of the right eye, this is the left side of the right eye, this is the right side of the left eye, and this is the left side of the left eye. So you can see right side of the right eye and the left side of the left eye is going. So this is actually bitemporal. Bitemporal hemianopia. It's a bitemporal hemianopia. What is the probable site of the lesion based on the image? It's bitemporal. It's not called as hemitemporal. It's bitemporal. And the site of the lesion is what? So what is the site of the lesion? Bitemporal is found in the optic chiasma. And here optic chiasma they have given as number 3. Therefore answer is number 3. Answer is simple. Optic chiasma hai. Chiasma means the crossing over. Crossing over takes place in the nasal fibers. Nasal fibers will lead to bitemporal hemianopia, and therefore the answer is number 3 here. Right? Now coming to the next question. Following the cataract surgery, patient is coming with again diminution of vision, and see they have told you the diagnosis also that there is a posterior capsular opacification. They are asking directly the treatment, but nowadays you will see that they will not even tell you the diagnosis, they will ask you the diagnosis of the treatment. So when we have again diminution of vision after the cataract surgery, it is PCO. Can you tell me the two types of PCO, guys? Two types of PCO. Treatment is same for both. That is your Nd:YAG laser posterior capsulotomy. Posterior capsulotomy, Nd:YAG laser posterior capsulotomy, and this is the most common laser that we are using in ophthalmology. 1064 nanometer, very very important. Tell me the two types of PCO. And the mechanism of action here is photo disruption. Another important question is the photo disruption. You should know the two types of PCO, 1 and 2. One is the Somering's ring cataract, and another is the Elshing's pearl cataract. Somering's ring cataract, Elshing's pearl cataract, and both are treated by the same thing, Nd:YAG laser posterior capsulotomy. Most common laser used in ophthalmology. The wavelength and the mechanism of action are the other important questions, right? Then coming to the next one, we have a 68-year-old female who is coming with diabetes. So diabetic cataract, they are asking it, if we are having a cataract in a diabetic patient, then what is responsible for it? It is actually the sorbitol pathway. Very, very important. And you should also know the enzyme. Enzyme is the aldol reductase. Aldol reductase. It is the aldol reductase enzyme. So these things have been asked many times. We have the aldol reductase enzyme, sorbitol, along with the fructose sorbitol pathway here. And another important thing is that the clinical feature that you get is the fluctuation of the refractive error. Fluctuation of the refractive error is the another important thing. The most common symptom that we are getting in the patients of the diabetic cataract, it is a fluctuation of refractive error. But guys, can you tell me the name of cataract which we are talking about? Sorbitol pathways, we have fructose accumulation, we have fluctuation of refractive error. This is the metabolic cataract. This is actually the metabolic cataract, that is snowflake cataract which is found, but it is not most common cataract in diabetes. Most common in diabetes is the pre-senile cataract. So there are certain questions which definitely comes with the diabetic cataract, and most of the times there is a confusion. The most common cataract found in diabetes is not snowflake cataract, it is the pre-senile cataract, right? Then coming to the next one. Now again guys, this is very very important. If you see, professor is coming with the vision loss in his left eye, and if you are getting curtain like effect in the eye with flashes are there, photopsia are there, floaters are there, and they are also giving you history of cataract surgery, and even the B scan also they have given you. So whenever guys, we have the curtain like effect. We have the curtain like effect along with the photopsia and the floaters. Photopsia and the floaters, and they are telling you the cataract surgery, it is a late post-operative complication. So which late post-operative complication of the cataract surgery can present with the curtain-like effect, photopsia and floaters? It has to be retinal detachment. Which retinal detachment? Which kind of retinal detachment it is? It is actually the RRD. The most common type of RD, that is RRD. This is the kind of retinal detachment that you are having. And on the B scan ultrasound, they have given you the B scan ultrasound. On the B scan ultrasound, we get the total funnel shaped RD. We are getting the total funnel shaped RD on the B scan ultrasound, right? Now, the 10th question. A 3-year boy is coming and he becomes clumsy for the past 6 months. He is becoming clumsy, and a very very typical thing, cauliflower like growth hai, along with leukocoria, no red reflex, and they are doing also the enucleation. Now, enucleation for a cauliflower like growth where you are getting leukocoria also obviously have to be what? Along with the flexner winter steiner rosettes also. I think they cannot give you a clue more than this. And I told you that whenever we are having leukocoria in a child less than 3 years of age, always consider it as a case of retinoblastoma unless proved otherwise. So answer has to be retinoblastoma. This is the severe most severe cause of the leukocoria. Most severe cause of leukocoria is actually retinoblastoma, and you have to consider any leukocoria in a child less than 3 years of age as retinoblastoma. Any leukocoria in a child who is less than 3 years of age, consider it as a case of retinoblastoma unless proved otherwise. Unless proved otherwise, you have to consider it as a case of the retinoblastoma. And the most common cause of the leukocoria, while the most common was the cataract. Now obviously for cataract you will not do enucleation. For the cataract you will not get the flexner winter steiner rosette, so there is no confusion that your answer is the retinoblastoma, right? All right, now guys, another major question. Which of the following combination of the lenses can be used to treat with the rule astigmatism? With the rule astigmatism means what? When we are talking about the astigmatism, guys, we have the two meridians. One is horizontal meridian and one is the vertical meridian. Okay. Now, if the vertical meridian power is more than the horizontal meridian, then I would say it is with the rule astigmatism. When the power in the vertical meridian is more than the horizontal meridian, right? Now, another important thing is that the power of the cylinders will always act at the perpendicular axis. So, in whichever axis you are giving, the power will be acting in the perpendicular axis. Like if I talk about the A option, plus 5, they are giving at 180. So, this will act at 90. While minus 3, they are giving at 90. So, it will act at 180. And you know that minus is more than plus. So this is against the rule astigmatism. This is option number A, against the rule astigmatism. Then number B. Number B, plus 7. Plus 7 will act at 90 and plus 5 here. Now again here, lesser the plus number, more is the power. So here also horizontal is more than vertical. This is also against the rule astigmatism. Now let me remind you that as the minus will increase, power will increase. But as the plus will increase, the power will decrease. While if you look at the option number 3, we have minus 4 and minus 5. C option mein we have the minus 4 and minus 5. So as the minus increases, power increases. This is also against the rule astigmatism. And finally, obviously, answer has to be D. It is minus 3. This is the option number D, minus 3 and plus 1. So obviously here minus 3 is more and therefore answer is D. It's a very simple question, but the thing is that you should know this. First of all, what is the meaning of with the rule and against the rule? Second, as the minus power increases, the power increases. As the plus power will increase, the power will decrease. Then you can easily do this question. I hope it's very, very clear, guys. Now coming to the half of the questions, your 12th question, a young boy is coming with the trauma, and after the trauma we are having monoocular diplopia. So one eye में two images, monoocular diplopia में one eye two images. One eye two images means that we are having the two pupils, and two pupils are formed in the cases of the iridodialysis, and that is why the answer is iridodialysis. Iridodialysis is again one thing which has been asked in your paper so many times. Here we will have the detachment of the iris. We are having the detachment of the iris from its root or its base. Detachment of the iris from its root is called as iridodialysis, and this will lead to the D-shaped pupil. This will lead to the D-shaped pupil. This is again important. Detachment of the iris from its root is called as the iridodialysis, and it will definitely lead to the D-shaped pupil. Both the things are important. Then coming to the next one. Now see this, guys. Question on the pinhole. So what is the basic concept of the pinhole whenever you are doing questions related to the how you can do? So pinhole say the vision is improving. If the vision improves on looking through the pinhole, then it's a refractive error. This is option number 1. If it is not improving, then it is, if it is not improving, or then we can say that there is some organic disease, some retinal disease. And if it is decreasing, if the vision is decreasing, then it is some macular lesion. So there are 3 interpretations of this pinhole test. Whenever you get a question related to this, is it increasing, is it decreasing, or it is remaining the same? If it is improving, it is a refractive error. If it is decreasing, it is some central lesion, some macular lesion. And if it is not improving, not decreasing also, then it is some organic disease. Then it is some organic pathology, that is like retinal disorders, right? Now, as the countdown is going, we are coming towards the next question. Again, a very, very important question. A farmer is coming here, and he is actually coming with he's coming with pain photophobia and watering. Now guys, why I have kept this question, because whenever we see that there is pain, photophobia symptoms, we always think about the bacterial ulcer. Now here in this question, we have pain, we have photophobia, we have watering, and ulcer is also there, but it is again not the bacterial ulcer. I told you signs are always more important than the symptoms whenever we are talking about this. What is the lesion here? So lesion you can identify only once you know what is the kind of ulcer. So if you see, this is the grayish ulcer, and you can also see the satellite lesions. So if you see the satellite lesions, grayish ulcer, it has to be the fungal keratitis. And you can see they are asking you the lesion is the satellite lesions. You cannot see hypopyon will definitely be there in the fungal ulcer, but here it is not visible. Talking about the other things, if I talk about the dendritic ulcer will be found in the viral keratitis. Ring ulcer is found in the acanthamoeba. This is found in the acanthamoeba keratitis. Therefore, your answer is option A. So, I have told you both how to identify the fungal keratitis, what are the evidences, and how to answer the question. Okay, right. Now, coming to the next one, again a very diagnostic question, and you cannot escape this question right away. Here we have a young boy who is coming with itching, watering, rhinorrhea is also there. Itching, the moment you see itching, that means we have the allergy. And allergy in a young boy obviously can be VKC, where you can get this typical cobblestone papillae is also given. Cobblestone papilla is given. They have given you itching also. Itching, allergy mein watering is also there. Then other evidence of allergy, like we have rhinorrhea. Then a very typical picture also they have given. So obviously this is the vernal keratoconjunctivitis. Trachoma is known for your Herbert follicles and Herbert pits you will have, plus you will have the sago grain follicles. Okay, so it's very different, the trachoma. And trachoma is again important because it is eliminated in 2024. Then bacterial conjunctivitis may most common will be the mucopurulent discharge. It will be mucopurulent discharge. And when I talk about viral conjunctivitis, when I talk about the viral conjunctivitis, then it is actually the hemorrhagic conjunctivitis, or it can be the follicular type of conjunctivitis, which is common in cases of the viral conjunctivitis. Then coming to the next one, now again a very typical picture that you get most of the times in your exam. If you are getting something like this along with the pain, proptosis, and loss of vision, then this is nothing but the orbital cellulitis. Orbital cellulitis is actually the most common cause of the proptosis also. It is the most common cause of the proptosis in the, which is unilateral. Unilateral proptosis in children ka most common cause is the orbital cellulitis, and the most common cause here is the Staph aureus. The infection is the Staph aureus. Yes. So definitely guys, remember these pictures. Look at the pictures very carefully so that you can remember them. All the pictures, all the words, all the topics, all the questions are extremely important. Coming with the next one. So this is a very typical question guys, and a very important topic. This was asked in NEET PG 2023 also, similar type of question, where they are saying that we have a 70-year-old patient who is coming, was using the presbyopia glasses for the past years, and now he is comfortable without the glasses. So if a patient can read even without the glasses, if he is comfortable even without the glasses, then what is this? This is actually the index myopia. And this index myopia is occurring in the nuclear cataract or the nuclear sclerosis. Nuclear cataract or nuclear sclerosis, which can lead to the second sight also. Second sight means the patient can read even without the glasses, and because it is occurring due to increase in the refractive index, therefore it is called as index myopia. We have increase in the refractive index, which is leading to increased power, and increased power leads to the myopia. Now, myopia means short-sightedness. Short-sightedness means diminution of vision for the distance, and there will be improvement of the near vision. So patient feels miracle. Patient feels that as if he has got some new sight, and this new sight is called as the second sight. Yes. So I hope people you are getting and able to revise all the important things. Now, another important question, patient is presenting with pain and redness, and they have given you history of trauma and with the welding. Welding is obviously a iron particle which is going into the eye, and you can see here also they are asking what is the next step. So you can see here this iron particle here, intraocular foreign body hai, which has penetrated. What you are going to do? Will you give steroids and antibiotics, surgical exploration, keratoplasty? I will not do the corneal transplantation for a foreign body, obviously, hai na? So I will not do surgical exploration, not required. You are easily able to see this. Now, antibiotics and steroids, they are asking you the next step. The next step is first you have to remove this foreign body, then you have to give the steroids under the antibiotic cover, because I have removed it, so a lot of congestion will be there. I will have to prevent the secondary infection. So this will be actually D, which is followed by A option. First, I will remove it by a needle, and then I will give the antibiotic cover. Okay. Yes. So that was the 18th question. Coming to the next one. Now, I cannot tell you the importance of this image. Means this image came in a NEET PG 2023 also. Although they had not asked the name, they had asked the name of the stain and name of the filter. You should know that also. Fluorescein stain and the cobalt blue filter. This is the typical dendritic dendritic ulcers हैं, which are found actually in the viral keratitis, and because we have the floor also, as well as the knobs are also there. We have the knobs also present. Because knobs are present, so these are the true dendritic ulcers, and true dendritic ulcers are found in the herpes simplex virus. Another important thing, the name of the stain. So name of the stain is the fluorescein stain. It is fluorescein stain, and the filter is the cobalt blue filter. Filter is the cobalt blue filter. Fluorescein stain along with the cobalt blue filter that is there, right? Then so this is another question where the patient is suffering from injury to the eye with the vegetative trauma, pain and photophobia. So this we have already discussed. This is the fungal keratitis. Now see this question, another important question guys, and I think that this question can come up this year. Again, this was a kind of question which was asked in NEET PG 2023, and we have a very specific kind of picture, specific kind of clinical features which are coming up here. We are having watering here, and a newborn is there, and they are giving you this image. So this is the typical scenario that we are getting in cases of Buphthalmos. Buphthalmos ka always remember that we have the blue baby boy and the bablu. So this bablu is a boy, and baby less than 3 years में it's common. We will get the blue sclera along with the BPL card. So they will give you the triad or any of the features of the triad, like we can have the blepharospasm can be there, then photophobia, we can have the photophobia, and then we can also have the lacrimation, blepharospasm, photophobia, lacrimation, then hazy cornea, very important. They can give you hazy cornea, they can give you the megalocornea. So here you can see that we are having the haziness, we are having the megalocornea, bilateral involvement. You can see watering they have given in the neonate, they have given. So obviously it is a case of ophthalmos. If it is only megalocornea, you will not get photophobia and watering. Cataract may you will not get watering. Cataract may you will not get megalocornea. Dacryocystitis may you will get watering, but there you will not get photophobia. Hazy cornea, you will not get megalocornea. So by the diagnosis of exclusion also you can do, or directly also, Bablu BPL card along with the classic triad. Right. Now, a very important fundus image. Here, paper cannot be completed without a fundus image. We are having a hypertensive patient who is coming with the sudden and painless loss of vision. Now, sudden and painless loss of vision means posterior segment. There is something in the posterior segment. Along with this, they have directly given you pale retina with a cherry red spot. Pale retina with the cherry red spot with the afferent pupillary defect is nothing with the apart from CRO. Posterior segment ke lesions, all the four are there. But in the CRVO, we will get the splashed tomato appearance, not this. And you are getting lot of neovascularization, lot of hemorrhages, not the pale retina. Cystic edema or cystoid macular edema may you will get the honey comb appearance. Here you will get the honeycomb appearance and not the pale retina plus RAPD. RAPD means it's optic nerve defect, so obviously it has to be CRU. If you look at the DD of the cherry red spot, if you look at the DD of cherry red spot, which is again important, always remember that it is the cherry trees never grows, never grows tall in the mud and the sand. Cherry trees never grows tall in the mud and sand. So this has to be a CRAO, which will have the RAPD present. Then we have the Tay-Sachs disease. Tay-Sachs disease is there. Then we have the Niemann-Pick disease. Niemann-Pick disease is there. Then we have gangliosidosis. Gangliosidosis is there. Then we have trauma, and it has to be the blunt trauma. Now, one more thing, guys. For your examination, this trauma is important, which can lead to macular edema. Collins, the Berlin's edema. This is also a PYQ. Berlin's edema occurring in the macula. Then we have this is the metachromatic leukodystrophy. Leukodystrophy is there, and then finally Sandhoff disease. So remember this. If you know this, then you are able to solve every question related to the cherry red spot, right? All right, now coming to the next one. Now, I have kept this question as well as VKC question because most of the times there is some confusion about the both. A young patient is coming with the history of contact lenses use and foreign body sensation, redness hai, watery discharge bhi hai. Now, even if they give you the picture of cobblestone papillae, remember guys, whenever we are having the history of contact lenses, any irritation which is localized, then this will give you the giant papillary conjunctivitis and not the vernal keratoconjunctivitis. Giant papilla hai, giant papilla mein it will be more than 0.3 mm. So this is actually a localized response. It is localized, and here you can get a localized response for the soft contact lenses. Soft contact lenses are more important than the hard contact lenses. It can be sutures, any sutures can irritated, or it can be the prosthesis, or it can be any prosthesis. It can be any soft contact lenses, any prosthesis, any sutures which can be irritating, having a localized response leading to giant papillary conjunctivitis. Then coming to the next one, now again a question where you cannot leave this question, you cannot have a paper without this question. A patient is suffering from trauma to the right eye with a punch, and which of the following is the most likely case? So, whenever we have a punch injury, fist injury, we have for this ball injury, any kind of ball, then this is always a blunt trauma. Then this is a blunt trauma, and blunt trauma will lead to the blowout fracture, will lead to the blowout fracture. And blowout fracture is most common in the inferior wall. Very, very important. This is um, showing you the teardrop sign. It will show the teardrop sign or the hanging drop sign. All these things along with this image is again very, very important. And then the showstopper question. In which of the following conditions anterior chamber depth is decreased? This picture is again very, very important. You can see here the acute red eye hai, or acute red eye can be in the acute congestive glaucoma and the acute anterior uveitis. In the glaucoma, you have the dilated pupil. You will have the dilated pupil, and here you will have the miotic pupil. And anterior chamber depth is also reduced, anterior chamber depth also in glaucoma. Therefore, you will have the answer as the angle closure glaucoma. So even this kind of question was there in the NEET PG 2024 May, where they gave this kind of picture with the irregularly dilated pupil due to the synecdoche, and there the answer was uveitis, and here the answer is glaucoma. So that's complete your 25 most important questions. I don't want to prolong the session for long because I don't want to waste your time. But the thing is that these are those 25 topics that I would like you to read in detail. Look at the images that I have shared here. Please see if anything about these topics you are not very sure of. Please read this. Please look at the images related to this and do these questions multiple times before your final exam. Uh, the unannotated PDF is already on my Telegram group. You can take that. Annotated PDF के लिए you will have to DM me. I will share at the DM. And for those who are seeing that live, share the picture of your live that you are viewing, and message me in the DM. I will share you the PDF there. And guys, all the very best for you for the upcoming paper. Like, may God be there on your side. May you work consistently and hard so that you can achieve your success. So thank you so much, guys. All the best. Happy ophthalmology. Goodbye, guys.